Good morning and welcome to today's wonderful morning with Dr. Murli Bharadwaj. Surgery. 30 questions come in the tomorrow's exam. We need to be doubly sure. Wound healing is the table number 1. There are totally 125 tables, sir. What is meant by healing by primary intention? Whenever any wound is there, they just get opposed. There is a very minimum scar. It is a clean wound. That is primary intention. The edges are not opposed. Healing is by formation of the granulation tissue, and there is a poor scar that is called secondary. Any contaminated wound or any delayed closure done by suturing is called tertiary intention. Similarly, clean, contaminated, dirty wound. Whenever there is any wound with no viscous opened, you call clean. Open but minimal spillage, you call clean, contaminated, and with inflammation, then it is called contaminated. And any pus, perforation, or a mold infected wound comes under dirty wound. So whenever there is a healing by tertiary intention, it requires grafting, whereas primary intention, you get the best scar. So what is the key feature of the healing by secondary intention, doctor? Healing by secondary intention is identified by granulation tissue. Is the hallmark. Okay. Now, a 28-year-old male with clean incised forearm laceration, edges opposed, minimal tissue loss is primary intention. A road traffic accident avulsed leg wound with a devitalized tissue. That is called as untidy wound. 50-year-old diabetic, old abdominal wound, discharging pus, coffee, South Indian. Dirty. Yeah. Right, doctor? Good. Now, the next favorite area is shock, bedsores, and response to injury. What is the most common site where elderly people, when they are bedridden, they get the bedsores, doctor? Ischium, more than greater trochanter, and sacrum, even heel also. Pressure ulceration is very common. Stage 1 bedsore means non-blanchable erythema, intact skin, but stage 4 means full thickness, bone, tendon, joint, everything get exposed. The most common type of shock is hypovolemic shock. So we have cardiogenic, obstructive, distributive, endocrine. That's how you divide the shock. Any myocardial infarction where the myocardium lost its contractility can lead to shock. Cardiomyopathy can cause shock. What is obstructive? The heart is unable to fill. If there is any cardiac tamponade with a lot of fluid around the heart, or any pulmonary embolism where the right heart is unable to pump into the pulmonary artery because of a severe pulmonary hypertension, or any pneumothorax that led to tamponading effect for the heart to get filled from the great veins, that's called obstructive. Any septic shock, neurogenic shock, anaphylactic shock, these are all called as distributive shocks. Now, doctor, 65-year-old non-blanchable erythematous ulcer over the ischium. This is how he will ask a question. It is stage 1. Similarly, hypotension, tachycardia, narrow pulse, cool extremities with shock, hypovolemic shock. Always a distributive shock will have wide pulse pressure. Wide ante systolic high, diastolic very low. Whereas narrow pulse pressure is a feature of hypovolemic shock, distributive shock is characterized by wide pulse pressure. Now, whenever there is a shock, there is a decreased blood flow, decreased perfusion to the tissues, decreased oxygen supply to the tissues that lead to shift from aerobic into anaerobic glycolysis. That means pyruvate will not enter citric acid cycle. Instead, pyruvate convert into lactate. That's the reason a serial serum lactate is a way to measure the septic shock. One of the parameters regularly sent in the intensive care unit. What is the size of the cannula is a favorite question. 16 gauge, 18 gauge. Smaller the gauge, larger the bore. Remember. So 90 ml per minute you can send with 16 gauge, 18 gauge by 60 ml. Once more, image-based questions will come. Which will have that green colored cannula is which one, yellow color is what, blue color is what, and all that. Just kindly review the cannula sizes in the Google. Now, whenever there is any shock, there is a Q-SOFA criteria. What is the Q-SOFA criteria, doctor? Systolic BP less than 100, respiratory rate more than 22, GCS less than 15. They're all the components. It's called Q-SOFA score. Favorite question. Now, what is the primary hemorrhage, reactionary hemorrhage, and secondary hemorrhage? Immediately during the surgery, bleeding happening is primary. Within 24 hours, because of any ligature you applied, slipped or clot slipped. Earlier, primary hemorrhage time में clot बना, वो clot slip हो गया post-operatively. So within 24 hours, you call reactionary hemorrhage. 7th to 14th day, you call secondary hemorrhage. That is because of the infection, sloughing, etc., etc. Right? Now, what is class 1 hemorrhagic shock? Less than 15% loss of blood. 15 to 30% loss, class 2. 30 to 40% loss, class 3. More than 40% is class 4. Here's what we need to remember. So whenever unconsciousness, hypotensive and Cheyne-Stokes respiration, that is an irreversible shock. A trauma patient has hourly urine output of only 2 ml per hour. BP 80/50, pulse 150 per minute, confused. So more than 40% blood loss, negligible urine, lethargy comes under class 4. A post-operative patient bleeds 12 hours after surgery due to slipped ligature. What do you call? Reactionary hemorrhage is what we need to remember. Good to see 3 online classmates. Can you please punch your voice, punch your comment whether my voice is loud and clear, doctor? Please. Yeah. First fluid that you give in trauma is crystalloid. There are 2 types of fluids, crystalloids and colloids. Ringer lactate, normal saline, ivanni kuda crystalloids. When will you give intraosseous access directly into bone? If the IV access is not obtained in 90 seconds in a shock patient, 1.5 minutes में मिल जाना IV line, नहीं मिले तो intraosseous. What is myocardial contractility index in a shock patient? Heart rate into mean arterial pressure will give you myocardial contractility index. Whenever there is any trauma, there is a hemopericardium, cardiac tamponade. What is the Beck's triad to recognize that? Muffled heart sounds, engorged neck veins with tachycardia comes under Beck's triad of the cardiac tamponade. So, doc, please solve these questions, Beck's triad, etc., etc. Now, what is the minimum urine output per day, below which you call oliguria? 400 ml per day. Otherwise, it is 0.5 ml per kg per hour. That means 80 kg person should have 40 ml of urine formed every hour. Serum sodium, if you look, hyperglycemia हो रहे तो For every 100 milligram per deciliter of rise of the glucose, అంటే 200 रहने वाले को 300 को चढ़ गया blood glucose, 1.6 milli equivalent per liter of sodium will decrease. So hyponatremia occur in hyperglycemia. That's what we should remember. Right? Now, normal values you should know, doctor. Sodium 135 to 145, potassium 3.5 to 5, bicarb is 22 to 28, please don't forget. Normal calcium is 8.5 to 10.5, magnesium is 1.8 to 3, and osmolarity is 280 to 295 milliosmoles per kg. Now, different scalpel blades, you need to be sure. Number 11 for abscess drainage, arteriotomy. So, number 11 looks like this, right? Then 15 for minor surgical procedures and 22 is for abdominal incision. Now, there are some incisions, Kocher subcostal incision for open cholecystectomy. Then Chevron's rooftop incision for Whipple surgery. Whipple means pancreatico-duodenectomy. Pancreas and duodenum सब कुछ निकाल देते whenever pancreatic cancer. That's called Chevron's incision. Fenelstein is very popular. Caesarean section. It is a transverse muscle splitting incision. So it is cosmetically very good for the women, right? Because it will go underneath the underwear. So there are many incisions. अगर time है तो देखो, नहीं तो छोड़ो, doesn't matter. Okay. What is this called? Mercedes-Benz incision. Like this, and like this. Typically, it is being done for the liver transplantation. We do Mercedes-Benz incision is what we should remember. Now, doctor, sutures. Definitely one question will come on the sutures. What are natural absorbable sutures? Catgut, chromic catgut, fasciolata, kangaroo tendon, and beef tendon, they're all natural. What are synthetic absorbable? Vicryl, monocryl, dexon, PDS, which is polydioxanone, maxon, polyglyconate, they're all synthetic absorbable. Natural non-absorbable are silk, cotton, and linen. Synthetic non-absorbable are praline, nylon, polyester, and polybutyrate coating. They're all. So what is catgut? Catgut is made from the sheep intestine, not from cat intestine. That's the only thing to remember. Okay, doc? So ఇది కొంచెం గట్టి చదవాలండి ఈ టేబుల్. జరూర్ ఆయేగా. Right? So totally 150 tables. Thank you. Now, 30-year-old patient with infected wound requires suturing. What do you apply? Monofilament nylon is the one which is preferred because of the less bacterial lodgement in that. A surgeon chooses a synthetic absorbable braided suture for bowel anastomosis. Which one is that? Vicryl. A metallic non-absorbable suture with high tensile strength is required. It is stainless steel. Our table in that I mentioned which suture for which specific situation, which is a favorite question of the examiner. Then what is the suture size? Higher the number of the suture, thinner and weaker it is. Then how do you do knotting? Reef knot, granny knot, surgeon knot. Most common knot used is reef knot. This is called reef knot. This often comes in image-based questions. What type of knot is this? Is examiner will ask. This is reef knot, whereas this is granny knot. ये दोनों में क्या फर्क है? एक इस दिख रहे हैं ना? नहीं, ये नीचे से डाल रहे ना, ये इसके ऊपर से जा रहे. That's granny goes above, and granny slips. Nobody uses granny. Granny can slip. So slips easily, not recommended. Surgeon's knot more secure than the reef knot. Reef knot is most commonly used knot. Is what 3 points you need to remember. Now, a subcuticular suture is planned on abdominal wound. Which suture material? Subcuticular and typically if there is any injury on the face, you can't put a very ugly looking one. Subcuticular sutures will be cosmetically easy. So vicryl or monocryl is the one which is used for the subcuticular suture. Which slips? Granny knot. Granny can slip and fall, no? You can easy to remember. In an interrupted suture, what is the angle for the needle to enter the skin? 90 degrees. Okay. Now, different types of anastomosis, doctor. When you anastomose one part of the bowel into another part, removing the cancerous part in the middle. Yeah. The bowel can leak through that anastomosis, which occur on day 7. What is Jenkins rule? The length of the suture that you apply is 4 times the length of the wound. It's called Jenkins rule. Now, different types of needles. Soft tissue को suture करने वाला needle को round body होता. Skin suturing needle will have cutting needle. Epineuritis suturing needle will be reverse cutting needle. Exam में image based question देते. इसको क्या बोलते हैं डॉक्टर साहब? Taper needle, round body needle. This is called reverse cutting needle. This is the conventional cutting needle. So for intestinal anastomosis, you need to pierce through soft tissue. Hence round body needle. So this is an example of what? Round body needle. On postoperative day 7, patient develops peritonitis after a bowel surgery. That is due to anastomotic leak. Day 7. Now, ligature. What is ligature? Basically, for you to clamp the bleeding blood vessel, we use an instrument like this called ligature. So typically, this will be an image-based question. Gynecology, urology, colorectal, many places. So here what you are using, both pressure plus energy, leading to vessel fusion. And if you seal the vessel with this, even 3 times the systolic pressure you try to open, they won't open. Adi funda, ligature. I'll leave the literature for you. Now, surgical site infection, there are 2 scales. One is called Southampton scale, other is called asepsis. What is asepsis? Serous discharge, erythema, purulent discharge, separation, isolation of bacteria, if wound culture jeste. Similarly, more than 14th day, infection is called severe surgical site infection. Right? Then what is Southampton's? After you have done a surgical incision, normal healing with bruising, erythema, hemoserous discharge, or if there is pus, accordingly, Southampton scoring system is for surgical site infections is what we need to remember. So that is the reason until exam is over, good to see 5 online classmates. Good, doctor. Very good. Please punch the voice loud and clear for all of you. Now, So a laparoscopic thyroidectomy is preferred. Which energy device do you prefer to sealing? Harmonic scalpel. You try to go and see how it looks like on the Google images. This is an image-based question. Okay, doc? Now, cellulitis, gangrene, laparoscopy. Let's talk about them. Right? Then, what is a laparoscopic needle called as? Veress needle. Let's see how it looks like. This is called Veress needle used for laparoscopy. Don't forget. What gas will you insufflate the abdomen during laparoscopic surgery? Carbon dioxide at a flow rate of 1 liter per minute. How much intra-abdominal pressure is maintained? 12 to 15 millimeters of mercury at the time of laparoscopy. A diabetic patient develops a necrosis of the scrotum with a foul-smelling discharge. What is that called? Fournier's gangrene. No, doctor. Different laparoscopy techniques. What happens when you're doing laparoscopy? Cardiac output decrease, lung compliance because diaphragm cannot move easily. Then PO2, splanchnic blood flow, all of them will decrease, whereas central venous pressure, pulmonary capillary wedge pressure, which is a reflection of pressure in which chamber of the heart, doctor? Right. Champesa. Left atrium. Yeah, left atrium. మనం చదివినాం కదా cardiology. So, what are the complications of laparoscopy? Laparoscopy can lead to gas embolism, pneumothorax, emphysema, subcutaneous crepitus, etc. Okay? ఇవి ధనాధన చేసేయండి డాక్టర్ గారు. Now, आज 7th है 18 days ఇట్లా మీరు మన the moment I finish this and go, no, you will take just 1 hour to revise. That's once for all. Never you are doing anymore, no? Yeah. Everything else you are applying on the test. Yeah. Test లో ఇవే వస్తుంటాయి. మీరు సాల్వ్ చేస్తున్న టెస్ట్ రాట్లే ఈ క్వశ్చన్లు. మీ గెస్ వర్క్ ఏమైతే డైలీ ఇట్ కీప్ ఇంక్రీజింగ్. That is the whole purpose of preparation. Preparation is not really to ratta. The preparation's purpose is to basically guess better. Now, different types of burns. Superficial thickness burn, only epidermis, first degree. Superficial partial thickness burn, papillary dermis, second degree, it is also called. Deep partial thickness burn, inka dermis inka kinda reticular dermis will be there. That is involved. Full thickness ante epidermis, dermis, subcutaneous fat, bone also burnt. 4th degree. So this is an example of a superficial partial thickness burn. Partial thickness ka mane papillary dermis is involved. Right? And this is an example of a full thickness burn, where even the bone is burnt. Now, examples. Sunburn, scald, friction burn, they're all first degree. Blisters form in second degree. Pinprick sensation will be there. Mandutunnattuntadi. Hot water padthe. It heals in 2 weeks. Third degree, it is white, dry, takes more than 3 weeks, and there is a hypertrophic scar that will form. And full thickness burn there is no pain. Full thickness ho gaya to pura nerves bhi burn ho gaya. So anesthetic, leathery feeling will be there. Right? And 4th degree burns often extend to muscle and bone is what we need to remember. Okay? So, a burn patient who has got a white, dry skin with no pain and leathery feel, what type of burn is it? Full thickness burn. Very good. Now, Falkland's formula. 4 ml per kg per percentage of the body surface area. First half in first 8 hours and next half in next 16 hours.
For the fluid.
Fluid. ఇప్పుడు మీరు 60 kg. So 60 kg into 4 is 60 kg, 30% burns అనుకోండి. So 60 into 30 into 4. 1800 into 4, 7200. 7200 में first half in 8 hours and remaining over next 16 hours. అది calculate correct గా చేసి పెట్టాలి. Then what is modified Parkland? After 24 hours only 5% albumin, no more crystalloids. ఇది after 24 hours. Then Parkland's formula can be applied up to maximum how much of body surface area involvement? Up to 50%. Kontamandi people will come with 70%, 80% burns. Typical ga Deepavali and Dashara, Vijayadashmi, and Deeparadhan untadi. At telvakunda cheera kongu kankunte katamiga. They get this thing. So whenever there are contractures because the burns, they are treated by Zudplasty. This is called Zudplasty, with which contractures are being removed. Right? Now, 40% burns, 30-year-old with ringer lactate. How much fluid is given in the first 8 hours? 50% of the total calculated. A burn wound in the neck with a tight eschar with a reduced venous return require eschorotomy. Right? Then doctor, grafting. Grafting में होता है split thickness graft, full thickness graft. What are the differences between the two? Split thickness माने epidermis plus part of the dermis को कहते हैं split thickness. Thiersk graft. Split thickness कहाँ से निकालते हैं? Abdomen, buttocks and thigh. And what is the thickness of it? 0.01 to 0.025 inches. What is the advantage? Large donor area can be removed, easy to harvest, and you can reuse the donor site. Mala skin grow aithe mala harvest cheyochu. Split graft disadvantage, cosmetically not superior. It can lead to hyperpigmentation, contraction. So this is split thickness where part of the dermis you cut. Epidermis, dermis together you call full thickness. So this is an example of a split thickness graft. Coming to full thickness को क्या कहते हैं? Wolf graft. Epidermis plus full dermis, no fat. Best site grafting कहाँ के लिए ये full thickness बनाते? It is cosmetically superior. Face, especially preauricular area. So ये area submental area से निकाल के preauricular area में grafting के. Right? So wolf graft इसको कहते. It is more cosmetically better, more durable and less contracture. But it has got very limited donor sites and it can lead to more amount of contracture than split thickness. ఈ differences గుర్తుపెట్టుకోండి డాక్టర్. ఒక క్వశ్చన్ వస్తుంది. A skin graft of the face with good cosmetic results with minimal contracture. Best cosmetic అంటే wolfe. Then doctor, whenever you are doing grafting, you can do vascular pedicle grafts. So a lot of times questions asked, forehead में अगर if you are putting a vascular myocutaneous graft, which vessel you will depend on, supratrochlear or supraorbital? Then deltopectoral flap vessel is internal mammary artery. Latissimus dorsi flap vessel is thoracodorsal. Then in the breast, after doing mastectomy, you put a tram flap vessel. Transverse abdominal muscle flap. There it is a superficial epigastric vessel is the vessel of tram flap. గుర్తుంటుందా? ట్రై చేయండి. అది డాక్టర్ జనరల్ సర్జరీ కథం.
Okay.
ఎంత టైం అయింది?
30.
Good. Nice to see. What is the name? Sophia and others. Sir, where to find the PDF? We will send you, we will WhatsApp you the PDF, don't worry. Yeah. So, మనం ఎన్ని పేజీలు ఉన్నాం?
40.
Out of
240.
1/6 downloaded.
Yeah.
15%.
Yeah.
Huh?
Yeah.
Good, no?
Yeah.
Half an hour 15% అంటే 1 hour 30%.
20%.
Huh?
20%.
Huh.
Yeah. So 2.5 hours.
2.5 3 hours.
Yeah.
ఇది దాటి ఇవ్వదు.
So
కాకపోతే మీరు ఆ తర్వాత కొంచెం ఇది
ENT కూడా ఉన్నది అసలు దీంట్లో.
Huh?
ENT, I got the worst marks from yesterday's test.
రేపు పెట్టుకుందామా ఏంటి?
Yeah, okay. Yeah.
చాలా ఈజీ.
Oh,
ఈఎన్టీలో నాట్ మోర్ దెన్ 100 pages.
okay.
అన్ని పెద్ద పెద్ద సబ్జెక్టులు.
Then some cardiology also I was getting wrong.
Cardiology.
Yeah.
Cardiology is something that some are conquerable. ఏంటి dermatology, psychiatry, anesthesia are easy to conquer.
Okay.
Just we are short of another 15 marks.
Yeah.
And it's to be on safe zone.
Yeah.
And exam will never be tough as mock test, remember.
Okay.
Mock test actually purposefully people make it
Oh,
complex. But the pass rate is only 15-20%. So we should not look at the pass rate.
yeah.
Now, let's start esophagus. HSV esophagitis, Candida esophagitis, CMV esophagitis, 3 types. In Candida में endoscopy में white pseudo membrane will form, which is friable mucosa. Whereas HSV, herpes simplex virus, multiple punched out lesions, Cowdrey type A inclusions are characteristic of HSV. And we treat by using acyclovir. Cytomegalovirus, deep longitudinal serpiginous ulcers. And the treatment is with ganciclovir, CMV. What are the most common cause esophagus get perforated? Iatrogenic. Because Dr. Goodillingham is trying to learn endoscopy. In the process, he will manipulate and can lead to injury. And the most common site of the perforation of the esophagus is at the cervical esophagus, is what we need to remember. A 45-year-old with odynophagia, that means difficulty to swallow. Endoscopy showed deep longitudinal serpiginous ulcers. What is your answer? CMV esophagitis. A patient with esophageal perforation showing mediastinal emphysema, because the air in the gut will expand into the mediastinum. So what is the best test? Always gastrographin contrast esophagogram is the one which will help you. Now, doctor, whenever gastroesophageal reflux disease is there, the lower esophagus has lost its tone. So stomach contents are going up.
Yeah.
How do you monitor? You will do 24-hour pH monitoring. Is the gold standard for the GERD. And what is the most important mechanism? Transient lower esophageal sphincteric relaxation. Telozer is the underlying cause. The most common surgical procedure to treat the GERD is laparoscopic Nissen's fundoplication. So in this, what will you do? You will try to, the esophagus will enter to become the stomach. So you will try to tighten that hiatus, esophageal hiatus of the diaphragm, the top of the stomach being wrapped around the esophagus. Karke, you will suture. It's called Nissen's fundoplication. Then comes achalasia. Whenever achalasia is there, there is a dysphagia, which is more for the solids than, dysphagia, okay, equal for solids and liquids.
Okay.
Remember that.
Yeah.
If the dysphagia is more for the solids than liquids, it is any cancer. Esophageal carcinoma can lead to dysphagia for solids more than the liquids. Okay, doc? Now, so what is this called? Rat tail appearance when there is an achalasia cardia. When you do the barium, what is the main problem in achalasia? The lower esophageal sphincter failed to relax. That's the reason it is very narrow. And that led to the dilatation of the esophagus, unable to propel through the sphincter. And there is a collection of the barium. That's what we need to remember. Okay. Now, what is the manometry finding in case of achalasia? There will be no peristalsis. There is no lower esophageal sphincteric relaxation is the manometric finding. How do you treat? Non-surgically, you can pass a pneumatic bogey balloon and dilate and weaken that sphincter, lower esophageal sphincter, which is spasmodic. Otherwise, you can make a small nick called Heller's cardiomyotomy. Cardio means not heart. The cardiac end of the stomach, where esophagus is meeting. There you do myotomy. There's a longitudinal cut into muscularis propria that will weaken the lower esophageal sphincter. So the bird beak appearance is the hallmark of achalasia. And always you need to do endoscopy, mainly because of what? You don't know whether dysphagia is because of the esophageal cancer. It is a serious business, cancer. So try to rule it out, even though clinically everything is okay. So what is the gold standard to diagnose achalasia? You do the pressure measurement of the lower esophageal sphincteric area. So esophageal manometry is the gold standard diagnosis. 24-hour pH testing is the gold standard for gastroesophageal reflux. Manometry show no peristalsis, no LES relaxation. What is the diagnosis? Achalasia. Right, doc? Now, diffuse esophageal spasm. Whenever it is there, what do you see, doc? We find corkscrew appearance, like you open the champagne bottle. Then what is dysphagia lusoria? In few people, there will be an aberrant subclavian artery originating from the aorta that will go and compress the esophagus. Aberrant subclavian artery compressing the esophagus is called dysphagia lusoria. Nutcracker's esophagus. There will be a high amplitude, more than 180 millimeters of mercury. Peristalsis. That's called nutcracker. So you need to decrease the amplitude of the contractions of the esophagus. That you will do by using calcium channel blockers, anticholinergics, etc. Scotch-Keys ring is a ring that forms at the squamocolumnar junction. So this is the esophagus. Then this is a hiatal hernia. The stomach has moved up into the thorax. Between the two, you will find one Scotch-Keys ring. Okay? So Scotch-Keys ring is a B ring at squamocolumnar junction. Treatment is you need to do dilatation if the lumen has shrunken to less than 1.3 centimeters. Now coming to the esophageal diverticula. The most common esophageal diverticulum is a pulsion diverticulum. Pulsion diverticulum ko mucosa and submucosa only. That's the reason it is called false diverticulum. Then you have Jenker's diverticulum. There's an area which is called the Killian's triangle. Right? So this is the cricopharyngeal muscle. So the Jenker's diverticulum will form. This is the foot pipe. esophagus. Here the food get collected, it lead to halitosis, foul smell through the mouth that keep coming. So Junker's diverticulum comes through the Killian's triangle. The cause is a cricopharyngeal muscle dysfunction. It presents with dysphagia and halitosis. If it is less than 2 centimeters, do cricopharyngeal myotomy. If it is 2 to 6 centimeters, you do myotomy and diverticulectomy. Remove that. If it is more than 6 centimeters, you need to do myotomy and diverticulopexy. You need to repair also from the future diverticulum forming, pexy. Then what is traction diverticulum? In this, all layers contribute to the diverticulum. It's a true diverticulum. So whenever there is any infection like TB or histoplasmosis involving the esophagus, if it happened to heal by the fibrosis, it can lead to the development of a traction diverticulum, which typically happens in the mid part of the esophagus, is the location for traction diverticulum. Clear, doctor? So how will examiner will ask? Corkscrew esophagus. Jump and answer. Diffuse esophageal spasm. Killian's triangle. Jump and answer Junker. Mid-esophageal, TB, jump and answer traction. Dukde, thaggedila. When you go to the exam, no? What is the sign that you are going to get the top rank? If you are enjoying, lesser mortals who didn't have guts to get up at 5 o'clock in the morning and do revision. They were all crying like a midnight owls. Ankari? Like, Adolf Hitler says, German race is the only race and all others are inferior race. Atla, robust aggressiveness undala preparation ante. One time in life we prepare, doctor. And that will remain in our yadon mein reh jata. I might have been teaching right when I was in second year MBBS. Trust me, in this 26 years of my teaching, last 4 months is the most memorable part. Definitely, I'll relish that forever. So, the most common type of hiatus hernia is sliding hernia in 85% of cases. There are two types, doc. One is called sliding hiatal hernia. There is a herniated portion of the stomach going up, crossing the diaphragm, where gastroesophageal junction in the that has moved up. Here, gastroesophageal junction is below diaphragm only, but a portion of the stomach got herniated from the greater curvature. That is called paraesophageal rolling hernia. Idemo sliding hernia. Adi main. So all of the differences you should know. Most common type sliding. Gastroesophageal reflux disease associated with sliding. A lot of people with acidity. When you do esophagus, upper GI endoscopy, you will find sliding hernia. Paraesophageal hernia is the true hernia, only stomach, a part of it get herniated, not the gastroesophageal junction. In that it stays in the abdomen only. Rolling hernia na paraesophageal hernia na anni okate. Same. Paraesophageal hernia has a risk of leading to the volvulus of the stomach. It can twist, it can strangulate. And if you do the chest X-ray, you will find a gas bubble and a fluid level behind the heart. I could not get this, but please check favorite image-based question. How will a rolling hernia look like on X-ray on the Google images? What is the best investigation? Dr. Barium meal is the best investigation for detecting the hiatus hernia. Sliding hernia, not rolling. There is a GERD. Clear? Now, doctor. This is interesting. A patient has hiatus hernia, colonic diverticulosis, also gallstones. What is this called? Saint's triad. That's the reason whenever we eat the food, we should have fiber. If the fiber is not there, the gut need to use a lot of pressure to push the food that we have eaten through the tube. That lead to hiatus hernia, diverticulosis, and also the people who eat a lot of fat food without fiber will develop gallstones, which is called Saint's triad, is what you need to remember. Now, doctor, what is Barrett's esophagus? Squamous to columnar epithelium with goblet cells. Squamous is replaced with columnar cells, which has got goblet cells, is called intestinal metaplasia. Is the Barrett's metaplasia. Now, I'll leave the literature for you. Classic Barrett and a more than 3 centimeters, short segment and a less than 3 centimeters. Oh, pulihor is so the main funda Gurjana दिमाग के अंदर. Very good to see 5 online classmates. So, doctor, every day, early morning, 5 o'clock to 9 o'clock, I'm all yours. I want to give you a habit. People think being awake 1 o'clock, 2 o'clock, they are reading. They are not reading. They are spoiling their internal endocrine system. So, please don't do that. Because last 20 days, 30 days of exam, soul, body, heart, mind, everything should tune. So it is little daunting 2-3 days. After that you will learn, enjoy. You see if your day, like 5 to 9 with Dr. Murli. Take a break, go to gym, exercise, whatever. 11 o'clock to 2 o'clock, take the test. Have a quick lunch, nap, get up, 3 to 4, do the review. And evening, whatever that we read, the previous things, 2-3 hours revision karo. 7 o'clock, you are a free bird. Be prepared to go to sleep by 10 o'clock. Adi. If you do that like 20 days, like a preparing for delivering a baby. Now, what is Patterson-Kelly syndrome or Plummer-Vinson syndrome? There is a dysphagia, esophageal web, and iron deficiency. Right? So there is also glossitis, tongue, koilonychia, spoon-shaped thing. And there is a risk of developing squamous cell carcinoma of the hypopharynx with the Plummer-Vinson syndrome. And middle-aged woman is the typical patient. So where will you do Barrett's biopsy? Distal part of the esophagus. And what is the hallmark? If you find the goblet cell का पोजीशन esophagus पे नहीं होता, अगर है तो वो abnormal है, वो है Barrett's esophagus, and it is at risk of developing adenocarcinoma. Whereas your Plummer-Vinson syndrome is at risk of developing squamous cell carcinoma. Adi, difference. Okay. Now, doctor, H. pylori produce urease, which produce ammonia, which alkalinizes the stomach pH. What are the 2 virulence factors? CAG-A, VAC-A. H. pylori will increase the gastrin level, leading to hypersecretion of the acid that leads to the development of ulcers. The B12 deficiency is linked with the gastritis of H. pylori because H. pylori will destroy the parietal cells that produce will destroy the intrinsic factor production that lead to vitamin B12 deficiency. H. pylori also associated with immune thrombocytopenia. A gram-negative S-shaped flagellated organism means H. pylori. And what is the important risk of H. pylori? It can lead to development of mucosa-associated lymphoma, which is maltoma. typically. Now, what is the triple therapy, quadruple therapy of H. pylori? Bismuth plus metronidazole plus tetracycline is BMT triple therapy. Omeprazole, amoxicillin, clarithromycin is OAC triple therapy. Then ranitidine, bismuth, clarithromycin plus metronidazole or tetracycline is RTC. And what is quadruple? Omeprazole, bismuth, metronidazole plus tetracycline is quadruple. Don't forget, one question will come every day in and day out practice wala mamla. Now, good to see 6 online students by 6 o'clock in the morning. Good. Now, chronic atrophic gastritis can be of 2 types. The one involving the fundus of the stomach, other involving the antrum of the stomach. So, fundal wala ko type A kehte, type B bane to antral. Antral is due to H. pylori. That is a place where your intrinsic factor producing cells are there. Whereas fundal wala is because of the autoimmune chronic atrophic gastritis. So type A gastritis mein, there is a pernicious anemia, adenocarcinoma risk. Type B mein, H. pylori and maltoma risk. That is the story of 2 types of chronic atrophic gastritis. Now gastric ulcer, duodenal ulcer. Story starts. Gastric ulcer, more than 50 years, you are already a professor of medicine. Gastric ulcer aayega if the PG is not listening to you. NSAIDs can cause gastric ulcer. Whereas H. pylori is more often associated with duodenal ulcer, younger patient who is eating Swiggy Biggie. Gastric ulcer pain soon after eating. Duodenal ulcer relieved by eating. इसलिए गैस्ट्रिक अल्सर वाले प्रोफेसर साहब ने खाना बंद कर देता क्योंकि थोड़ा खाए तो भी पेट में दर्द हो रहा है. Whereas duodenal ulcer fellow, he keeps on eating because that eating is relieving his abdominal pain, and that's the reason he is fat. Postgraduate eating through Swiggy is fat. प्रोफेसर साहब जो गैस्ट्रिक अल्सर है वो पतला है. Duodenal ulcer में no vomiting, but gastric ulcer leads to vomiting. Gastric acid level is high in duodenal ulcer. So what is the cause of duodenal ulcer? It is normal alkaline environment of the duodenum will neutralize the acid that has come from the stomach. If the amount of the gastric acid produced by the stomach is overwhelming the neutrality of the duodenal alkaline mucosa, that lead to ulcer. That's the reason hypersecretion of the gastric acid is the pathophysiology of duodenal ulcer. Whereas normal to low gastric acid is a feature of gastric ulcer. Adi gurtupeట్టుకోండి. అర్థమైందా? Normally duodenum as a protection. But if too much gastric acid produced beyond the protective ability of the duodenum, you get duodenal ulcer. That's the reason high gastric acid production is the feature of duodenal ulcer, but normal or low in case of gastric ulcer. Enter doctor number
68.
68.
Yeah.
Out of
241.
120 అయితే సగం అయినట్టు.
Yeah.
Now, pain in gastric ulcer increases the meal, hence no eating, weight loss. Pain in the duodenal ulcer decreases with the meal, hence good appetite and weight gain. The most common site of the gastric ulcer is lesser curvature. But if the gastric ulcer occurs on the greater curvature, it has a greater tendency to become malignant. Funda. Now, what is the cause of the gastric ulcer? Hang mats, H. pylori, aspirin, NSAIDs, gastronoma, men, multiple endocrine neoplasia. అందులో ఏముంటుంది మళ్ళీ గ్యాస్ట్రోనోమా ఉంటుంది, right? And that lead to excess gastrin production leading to gastric ulceration. Similarly, alcohol, tobacco, steroids. Now, what is the gold standard for gastric ulcer? Endoscopy. Then, which type of gastric ulcer is benign and malignant? Can you make it up? Yes, sir. Irregular gastric ulcer with smooth margin. Irregular with a raised, heaped up margin, malignant. Granulation tissue in the floor, benign. Necrotic slough in the floor is malignant ulcer. Radiating mucosal folds going towards the margin, benign. Distorted, thickened, not reaching the edge, mucosal folds, then it is malignant. Huh?
Yeah.
Then punched out or sloping, benign ulcer, edge.
Yeah.
Everted edge is malignant ulcer. Then 3 radiological signs: Hampton's line, Kirkland nipple, Carmen's meniscus. Hampton's line is a thin, lucent line which is projecting along the ulcer base, which is a sign of benignancy. Overhanging margin with a mucosal tag is a sign of malignancy. Semilunar configuration of the malignant ulcer, this called Carmen's meniscus sign, is a sign of malignancy. ఇది గుర్తుపెట్టుకోవాలి 3. Okay, doc. Then comes the most common site of the gastric ulcer, type 1, is antrum on the lesser curvature, right? Then in the type 1, acid level is normal. Type 2 involves body of the stomach and duodenal ulcer. Type 2 acid level is high. Type 3 gastric ulcer is pre-pyloric channel, high acid. Type 4 gastric ulcer is in the cardiac end of the stomach, more proximal. Type 5 is anywhere in the stomach and often NSAID related. ఇవన్నీ MCQs talks. The most common complication of the gastric ulcer is perforation. So what is saddle-shaped ulcer? Typically along the lesser curve of the stomach, you get a saddle, means saddle. Then what is hourglass stomach? Whenever there is a gastric ulcer, there is a fibrosis of the lesser curve. Especially in women, you get what is called hourglass. Hourglass ante itlundi itluntadi.
Yeah.
Then which artery lead to the bleeding in gastric ulcer? Favorite question. Left gastric artery. Most common in which type? Type 2, type 3 la bleeding ulcer is very common. Type 2 का माना मतलब body and duodenal ulcer and pre-pyloric channel area. Cardiac end, pyloric end. Pylorus is where it is meeting duodenum. Cardiac is where it is meeting esophagus. Good to do. So chronic duodenal ulcer, will it become malignant? No, sir. Only gastric ulcer has a nature to become malignant when it becomes chronic. So what are the complications of a duodenal ulcer? It can undergo bleeding, perforation, residual abscess, pyloric stenosis can occur, right? Then different types of ulcer surgeries. Break this, Kunama.
Yeah.
75, na?
Yeah.
We'll take a 5-minute voice break. Time कितना हो गया?
7:40.
1 घंटा.
Oh.
మనోడికి ఒక మంచి ఫిల్టర్ కాఫీ చెప్పండి.
Yeah.
5-minute voice break. So, continuing our discussion on the various peptic ulcer surgeries, Billroth type 1, Billroth type 2, vagotomy plus pyloroplasty, proximal gastric vagotomy, and subtotal gastrectomy with Roux and Y. Let's see them. So, what is Billroth type 1, doctor? You have done a part of the stomach removed and connected with the duodenum. In Billroth type 2, you cut a part of the stomach and directly connect with the jejunum, bypassing the duodenum. Billroth type. So now, Billroth type 1 is partial gastrectomy with gastroduodenostomy, whereas partial gastrectomy with gastrojejunostomy is Billroth type 2. Type 1 is classic operation of choice for GU, whereas in Billroth type 2, it is typically you are leaving a blind loop. Then another way is all these parietal cells which are producing acid, they are supplied by vagus. So you do vagotomy to decrease the acid production, but that will decrease the motility because vagus is also important for the peristalsis. That's the reason you need to little relax the pylorus area. Otherwise, that lead to stagnation. So vagotomy plus pyloroplasty is a conservative surgery for benign gastric ulcer. Then proximal gastric vagotomy. With or without ulcer excision you can do, right? And whenever the ulcer is there at the gastroesophageal junction, then you do subtotal gastrectomy and Roux and Y. So I'll come to the Roux and Y when we talk about obesity surgeries. Okay. Now, what is selective vagotomy? Vagus is involved both in the motility of the gut and also in acid production. So why unnecessarily to affect the motility? Catch only that part which is involved in acid production. That's called selective, highly selective vagotomy is what you need to remember. So whenever you do vagotomy, you can do either pyloroplasty or gastrojejunostomy, Billroth type 2, to let the drainage happen. Right? So 55-year-old with benign gastric ulcer undergoes partial gastrectomy with gastroduodenostomy. That's called Billroth 1. Highly selective vagotomy with sparing of the antrum and pylorus. What is that called? Parietal cell vagotomy. Now, what are the complications that occur after doing gastrectomy? If you do vagotomy, there can be a diarrhea. Post-gastrectomy, iron deficiency can occur, megaloblastic anemia, calcium and vitamin D deficiency, and there can be stasis leading to post-gastrectomy, gallstones can occur. Why? Because unless the food enters into the duodenum, there is no cholecystokinin production that contracts the gallbladder. Suppose if you do vagotomy and prevent that drainage properly, then what will happen? There is a stasis of the gallbladder. Right. Then the duodenal stump you are leaving in Billroth type 2 can undergo blowout, typically on the 4th day. Please don't forget. So how does it present? A 50-year-old after Billroth type 2 develops a severe epigastric pain on the 4th postoperative day. then you suspect the possibility of the duodenal stump blowout. So whenever you are doing any of these peptic ulcer surgeries, you are cutting a part of the stomach. Because of that, stomach's normal function is what? It stores the food before slowly sending it into duodenum. So that part is lost. That's the reason there can be a sudden dumping. You call early dumping very common after Bildot type 2 would occur within 15 to 30 minutes after the meal. Now, what are the features of this early dumping? There can be epigastric fullness, sweating, tachycardia, lightheadedness, etc., are the part of the early dumping. And the cause of the early dumping is a rapid emptying of the hyperosmolar gastric contents is responsible for early dumping. Late dumping occurs 90 minutes to 3 hours after the food. And the late dumping kaiku hota? Typically, in the late dumping, because of the dumping, the glucose get absorbed into the blood that will stimulate the insulin, that lead to hypoglycemia, that will stimulate sympathetic system. So the vasomotor symptoms plus hypoglycemia that occur due to sudden entry of the glucose into the blood, leading to hyperglycemia, hyperinsulinemia, hypoglycemia, leading to sympathetic stimulation is late dumping. Whereas early dumping, because hyperosmolar contents jump into the duodenum, they will suck the water in the plasma into the duodenum, and because of that the plasma volume decreases, and that lead to epigastric fullness, sweating, tachycardia, lightheadedness. Anta hyperosmolar contents is early dumping. Hypoglycemia is late dumping. How do you prevent dumping? Frequent small meals, low carb, high protein, limit liquids. So what is the drug of choice? Octreotide for severe dumping. And dumping can lead to hyponatremia, hypokalemia, hypochloremia. And they're all the things that you need to remember. Then, whenever there is any hypertrophic pyloric stenosis, what will happen? Recurrent vomitings occur. Favorite question. Because of the vomiting, what will happen? Plasma volume decrease the renal plasma flow, decrease the GFR. Decreased GFR will go and stimulate renin-angiotensin aldosterone production. Aldosterone will cause the retention of sodium and loss of K plus H plus into urine. Loss of H plus into urine lead to metabolic alkalosis. Arthamainda? Ee sequence. Malla chepta. Cheppana? Avasarama? Following. Sometimes I'll be going fast. Fast appudu you need to hold the hand of the Lion King and go through the jungle. Whenever pyloric stenosis is there, there is a vomiting of the hydrochloric acid, which is there in the stomach. Continuous vomitings will decrease the plasma volume, and decreased plasma volume, decrease the renal plasma flow, decreases the GFR, increases the renin, angiotensin, aldosterone. The high aldosterone will lead to retention of the sodium and loss of K plus H plus into urine. Loss of H plus into urine lead to metabolic alkalosis. Why that is called paradoxical aciduria? One side you are vomiting acid and other side you are losing acid into urine. If you are vomiting acid, body thrust reflex should be to retain acid. But here you are losing acid. Hence it is called paradoxical aciduria. is what you need to remember. Now coming to gastric volvulus. The most common site of the volvulus is stomach. There is a Burchard's triad. Whenever the stomach undergo twisting, volvulus, there is a severe pain, retching, but no vomiting, inability to pass the nasogastric tube. So now, doctor, in those who are having trichotillomania, psychiatric illness, females, they will pluck their hair, they eat unknowingly, and that lead to formation of a hairball in the stomach, which is called trichobezor. Bezor means ball. Tricho means hair. So they will have alopecia, pain, abdominal pain, crepitus. That is the story of trichotillomania. Then what is hourglass stomach? Typically most common in women because of a saddle-shaped gastric ulcer, they develop a hourglass stomach due to cicatricial contracture. Now comes Wilkie's syndrome. It is also called superior mesenteric syndrome. So typically what will happen in this? You have the aorta, from that comes the superior mesenteric artery. Between the main aorta and the superior mesenteric artery, if the angle is 45 degrees, it can accommodate in the axilla, the duodenum. But if it is less than 10 degrees, then that get compressed. You get the duodenal compression. So that is the story of Wilkie. Because of the compression of the duodenum, the bile which enters the second part of the duodenum cannot go into third part, and that get vomited back. That's the reason there is a bilious vomiting, dehydration, weight loss in case of the Wilkie's syndrome. Here, what is the treatment? The duodenum is held by a ligament of treats that is being divided in order to release it. Okay? Now comes the Mentrier's disease. Giant hypertrophy of the rugae of the stomach is called Mentria, hypertrophic gastritis. In this, the acid levels are normal or low acid will be there. In the Mentriers, there is an excess protein loss leading to hypoalbuminemia with edema, classic hallmark. Most common site, body and fundus of stomach. Then what is trifoliate duodenum? Whenever there is a chronic duodenal ulcer, all that cicatrization will lead to clover leaf-like appearance when you pass the barium, which is called the trifoliate stomach. Right now? Then comes Zollinger-Ellison syndrome. Right. Good to see 5 online classmates. Please punch your name and is the voice loud and clear? Now, doctor. In Zollinger-Ellison, there is a gastrinoma, unregulated gastrin, acid hypersecretion, and ulcers. So where is the source? Who is producing all this excess gastrin? It is a non-beta cell endocrine tumor originating in the pancreas. Gastrinoma, pancreatic cells. Commonly 30 to 50. It can be sporadic, most commonly, or it can be part of the multiple endocrine neoplasia type 1. Parathyroid, pituitary, pancreas. All 3 central organs are involved in men1. Now, where is gastrinoma most commonly located? There is a gastrinoma triangle from where it originates. So, cystic duct or cystic duct and gallbladder opens through cystic duct and common bile duct. Then second and third part of the duodenum. And the neck or body of pancreas is another margin. So this is how the triangle is being formed. Okay, doc. So Zollinger-Ellison syndrome, gastrinoma triangle, you should remember. And commonly, it can originate from the proximal part of the duodenal wall where this gastrin producing cells can be there, or they can be part of the stomach also. I mean, or the part of the pancreas, endocrine pancreas. But most common site is proximal duodenal wall. Next most common is pancreatic head. So how do you know that there is a Zollinger Ellison? Ulcers present beyond the duodenum, that means jejunal, multiple ulcers, recurrent ulcers, and they can spread to liver, lymph node, bones, ovaries. They can spread anywhere. Most gastrinomas are located within gastrinoma triangle is what we need to remember. Okay. Now, so when do you suspect the Zollinger Ellison? When there are refractory ulcers, multiple or giant ulcers located distal to duodenum, like in jejunum. You consider jejunum. So how do you prove that? It is a gastrinoma. That's the reason fasting gastrin levels more than 150 picogram per ml is the indication. And we do somatostatin receptor scintigraphy in order to identify the Zollinger Ellison syndrome. That is the story. Few more points are there. Question is then linitis plastica. A diffuse fibrous proliferation with a thick rigid stomach is called linitis plastica, otherwise called as a leather bottle stomach. Saudi Arabian travelers on camel carry the leather bottle for drinking water. So what lead to this linitis plastica? Carcinoma stomach, lymphoma, metastasis, TB, Crohn's, sarcoidosis, radiation, corrosives, anything can cause. Coming to bariatric surgery. Any BMI more than 40 or more than 35 with comorbidities is bariatric surgery indication. You can do gastric banding, stomach ko band karo, sleeve gastrectomy. They're all the different procedures. So there are two types of bariatric surgery called restrictive bariatric and malabsorptive bariatric and combination. Sleeve gastrectomy is restrictive. You are restricting it. Then biliopancreatic diversion. So you can see vertical banded gastrectomy, gastroplasty. Clip dal dete. Then laparoscopic adjustable gastric banding, LAGB. Then what are the metabolic therapies? Transoral gastroplasty. This is called TOGA. Mouth is a natural orifice, no? So these are called as natural orifice transluminal endoscopic surgery. But if interventional radiologist అయితే ఓపిక ఉంటే ఇవి కూడా చేసుకుంటా పోవచ్చు. You can avoid, you can give a run for money to gastroenterologists. Always there's a competition between interventional radiologists and everybody else in the world. Future is all interventional only. Nobody will do conventional. So TOGA, transoral gastroplasty, is a type of natural orifice transluminal endoscopic surgery procedure. It involves using the instruments inserted through the mouth to perform the surgery, especially gastroplasty, which will alter the size of the stomach. For example, what is TOGA, what is nodes, try to remember. Then this is called Roux-en-Y gastric bypass. Stomach को bypass करोगे, एक gastric pouch बना के directly jejunum को खींच के कनेक्ट कर दो. Roux-en-Y. So that stomach ఉంటే బాగా తిని అందులో స్టోర్ అవుతుంది కదా. So that doesn't happen. So there's a bypassed portion of the stomach, long Roux limb. This is the pouch. That's the point. Biliopancreatic diversion. Okay. Now, doctor, the most common cause of the upper GI bleeding is duodenal ulcer. And there is something called Difflois lesion. A large caliber artery in the stomach can undergo massive hemorrhage, which is called Difflois. So basically, gastrointestinal, GI bleeding can be lower and upper. Lower GI bleeding, most common cause, diverticulosis. Typically, gut wall into small intestine, అందులోంచి pouches herniate అవుతాయి. Those herniating pouches are diverticulae. When there is an inflammation into that wall of the diverticulum, diverticulosis, that lead to development of the lower GI bleeding, most common cause. Typhoid, salmonella. It can involve the gut. Typically, it involves the distal part of ileum, which is very rich in lymphoid tissue. And remember, the typhoid perforation is typically longitudinal. TB is horizontal. So it is parallel to bowel axis. And usually third week of illness may, when patient is clinically recovering, suddenly perforation can occur in case of typhoid. The most common site of intestinal TB is ileocecal area. Right? Now, there are two types of TB, ulcerative type, hyperplastic TB. Ulcerative type is due to swallowed bacilli, it leads to a napkin ring-like stricture. ఇది ఒకసారి Google image देखना. How does a napkin ring stricture of the ulcerative TB looks like? There is a mass lesion in the terminal ileum is hyperplastic TB. That's the story. Okay. Now comes the Meckel's. Meckel is a true diverticulum, the most common intestinal diverticulum. The most common acquired diverticulum occur in sigmoid colon. Meckel is congenital. Persistence of vitello-intestinal duct. Whereas acquired and fat food dini fiber lekunte sigmoid diverticulum. Most common. Sigmoid colon. What is the rule of 2 in Meckel? 2% people 2 inches long, 2 feet from ileocecal bath. And how does it present? Diverticulitis, pain, fever, leukocytosis, and left lower quadrant tenderness. Because sigmoid colon is involved, no? That's the reason. And always CT scan is the gold standard of diagnosis. And in all the acquired diverticula, there is no muscularis layer. That's the point, right? Then diverticulitis. Hinchi classified the diverticulitis. Hinchi grade 1, mesenteric and pericolic. Hinchi grade 2, pelvic abscess due to diverticulosis. Diverticulitis. Purulent peritonitis, Hinchi grade 3, fecal peritonitis, Hinchi grade 4. And the most common cause of acute LGIB is lower gastrointestinal bleeding is diverticulosis. So how do you treat? If it is a Hinchi grade 1 and 2, antibiotics and ultrasound drainage. Hinchi grade 3 and 4, do laparotomy and do Hartmann's procedure. Remove the area where the diverticulum is there. Below that, you try to close it as a closed loop. And above that, what will you do, doctor? Above that, you open as a stomy. That's called Hartmann. That is for diverticulitis grade 3 and 4. 3 means purulent peritonitis, 4 means fecal peritonitis. Don't forget. The most common vessel involved in acute mesenteric ischemia is superior mesenteric artery, not inferior. The most common cause is an embolus coming and blocking the superior mesenteric artery, leading to the intestinal ischemia. So what is the hallmark? Pain, doctor, after eating food. That's called intestinal angina. Postprandial, खाने के बाद pain unbearable है. But there are no signs of peritonitis or abdominal rigidity or etc. Rebound tenderness, which are seen in the peritonitis and all. So severe pain disproportionate to the signs. Pain is a symptom. Symptom disproportionately present to that of the signs is an indication of acute mesenteric ischemia. So what led to that embolism into the superior mesenteric artery, leading to the mesenteric occlusion, doctor? Atrial fibrillation. Even atherosclerosis in elderly people of the superior mesenteric vessels can lead to intestinal ischemia and abdominal angina. So any nausea, vomiting, bloody stool, shock in an elderly man should make you to suspect. So what is the earliest sign of acute mesenteric ischemia? The bowel wall become edematous. If you pass barium, it is called thumb printing sign. And barium is a indicator. Anthony, ఎన్నో పేజ్ నడుస్తుంది?
95.
201 total?
241.
120 కొద్దామన్నా ఉద్దేశం ఉందా ఓపిక?
Yeah, one second. Sorry, let's use the washroom.
So we'll take a 2-minute voice break. So, welcome back to the session, doctor. So, the earliest X-ray sign is mesenteric artery ischemia is the bowel wall edema leading to thumb printing sign. Now, angiodysplasia. It is a vascular formation in the elderly people above the age of 60 years. It typically involves cecum, ascending colon, most common location. Favorite question. Sometimes an elderly man continuously going into anemia with melena, and you have done endoscopy, nothing is found. Then the underlying cause is angiodysplasia. That can't be identified on simple colonoscopy. So that's the reason you need to do the angiography to identify the dysplastic, angiodysplastic lesions, which are responsible. So this is how typically a vascular malformation can look like, angiodysplasias. So a 65-year-old with atrial fibrillation develops severe abdominal pain out of proportion to findings and lactic acidosis and shock. What's your diagnosis? Acute mesenteric ischemia, which can occur because of embolism due to underlying atrial fibrillation going into the superior mesenteric artery. 72-year-old with painless, very important, painless lower GI bleeding. Colonoscopy show vascular ectasia. What is the diagnosis? Angiodysplasia. If there's a fecal peritonitis, what is that Hinchey grade? Hinchey grade is grade 4 is what we need to remember. Good to see 7 online classmates. Whatever. Very good, doctor. Every day, early morning, 5 a.m. to 9 a.m. with Dr. Murli Bharadwaj. Next 20 days, I'm going to become 25 years younger to study with you like your classmate. Now, doctor, ischemic colitis. It is the embolism more common than the thrombosis. So what is the most common site of the ischemic colitis, ischemia? Most vulnerable area is transverse colon. It has a hepatic splenic flexion. Splenic flexion is the watershed zone. It's called Griffith point, is most common site. Now coming to ileostomy, colostomy. The effluent that comes when ileum is being brought out is still liquid rich in fluid electrolytes. Colostomy, it is solid. It has low fluid or electrolyte loss compared to ileostomy. Ileostomy is opened into the right iliac fossa, colostomy into the left iliac fossa. Ileostomy is spouted, colostomy will flush. And that is the typical differences. Then intestinal obstruction is divided into adynamic and dynamic obstruction. Adynamic means peristalsis is absent. It's called paralytic ileus or pseudo obstruction. Dynamic means real organic lesion is causing the obstruction. The most common cause for the dynamic intestinal obstruction is the presence of adhesions. After you do surgery, postoperative adhesions, peritoneal adhesions are responsible for dynamic obstruction. Similarly, any hernia, stricture, intussusception, volvulus can cause dynamic obstruction. Right, doc? Now, closed loop obstruction. Whenever there is any sigmoid volvulus, no, with a competent ileocecal valve, it leads to a closed loop obstruction. There can be hernia of the intestine can occur along the fossa surrounding the duodenum. They are called paraduodenal hernias, are the most common site for the internal hernias within the abdomen, nothing protruding out. Now comes gallstone. Whenever the gallstone in the gallbladder happen to slip from the gallbladder and travel into the ileum, gallbladder lonchi oka track form అయిపోయి it will go to ileum and lead to the ileal obstruction. Then it's called gallstone ileus. So it is the terminal ileum where the gallstone ileus will most common site. And whenever gallstone ileus form, what is the triad of clinical features? One is pneumobilia. So typically from the gallbladder, the stone passed through the bile duct, and in the process it led to air leak into the liver, biliary system. So that's called pneumobilia. Along with that, that big stone came and led to obstruction. You can see the stone here. Can you see the stone? Big stone. Yeah. And that led to intestinal obstruction. That's the reason multiple air fluid levels are there. So this combination is called Rigler's triad, which is seen in the case of the gallstone ileus, is what we need to remember. So sigmoid volvulus is a closed loop with a massive dilatation of the sigmoid. And what is this called? Coffee bean appearance in case of sigmoid volvulus. Right? Now, what are the most common volvulus in neonates? It is the midgut malrotation. Embryologically, our part of the midgut will come out and then go back. If that rotation doesn't occur properly, then that can lead to midgut malrotation volvulus. The most common volvulus in adult is sigmoid volvulus. And what is the treatment of volvulus? You need to do decompression. You need to pass a flatus tube from the bag and then decompress it and do elective surgery. Then small intestinal bowel. Small bowel obstruction can be high bowel, low bowel. High bowel ante more towards duodenum. Low bowel is more towards ileum. High bowel will lead to early profuse vomiting and little distension. Low bowel more towards ileum will lead to late vomiting but a marked distension. Endukante duodenum jejunum anni bloat aithe. Right, doctor? Now, how do you radiologically identify the gut? There is a small bowel sign, small bowel obstruction unte. You find straight central segments and transverse air fluid levels. In the mundu shangara, regular stride. So, straight central segment, central. Small intestine all central, no? And the large intestine periphery. Then, small bowel obstruction, low, no gas will enter into the colon. So that is the reason normally you find gas in the colon, but no gas in colon is an indication of the small bowel obstruction. Jejunum has got valvulae conniventis. They cross the wall, they lead to stepladder pattern. So let us see, what is this called as, doctor? Valvulae conniventis, which is the hallmark of the jejunum, where they give that stepladder pattern. Ileum. How do you identify ileum? It is called featureless. It has no feature. Then cecum. Cecum will lead to a round gas shadow in the right iliac fossa. Right? Right iliac fossa. Then large bowel contain haustri. How valvulae conniventis differ from haustri, doctor? Haustri are incomplete, conniventis are complete. Irregular or haustri, regular or conniventis. And whenever jejunum get obstructed, it typically lead to stepladder pattern. Okay. Now, in small bowel obstruction, the X-ray will show multiple air fluid levels centrally located. Now, Ryle tube, nasogastric tube, it will decompress the intestine. So that's the reason whenever somebody comes with an abdominal distension, first thing you do is put a Ryle tube so that air goes out. The most common ingredient of the abdominal distension is swallowed air. That's the reason you put a Ryle tube. And the Ryle tube length is measured nose, ear, xiphoid, beyond costal margin. Okay. Now, you can see these are the examples of hostal folds. Hostal folds are typically incomplete in large bowel obstruction. Now, doctor, pseudo obstruction usually affects the colon. Any neuropathy, myopathy, systemic diseases, hypokalemia, diabetes, uremia, myxedema, porphyria can make the gut become lethargic, not peristaltic, leading to adynamic obstruction, which is also called pseudo obstruction. Similarly, tricyclic antidepressants which have an anticholinergic action. Acetylcholine stimulates the gut, anticholinergic stagnates the gut. So, laxatives, phenothiazines can lead to pseudo obstruction. Then comes rectal prolapse. అయిపోయిందా petrol? Any 2 घंटे? 10 minutes, no problem. Another 10 minutes we are ending. कितना हो गया? 108. మనం 120 అయితే 50%. Good. ఇవన్నీ మళ్ళీ చదవాలి. You want this because the one which I sent you doesn't have highlights.
Yes.
Better this
Yes.
one. Now, rectal prolapse, mucosa, submucosa, both of them will protrude outside the anus. Typically, third-degree hemorrhoids and rectal prolapse are both associated. What is meant by third degree? First degree spontaneously goes back. Second degree, digital push. Third degree, even digital push does not push it back. That is third degree. So how do you treat rectal prolapse? Digital repositioning or phenol injection. 5% phenol in almond oil under general anesthesia. So this is how rectal prolapse typically happen. Full thickness prolapse is also called precedentia, and it involves all layers of the rectal wall. Now, anterior rectal wall involvement is the most common location for anterior wall, posterior wall. Anterior wall is the one which is most often the one which prolapses in the rectum. Okay, doc? So now, complete rectal prolapse means all layers of rectal wall plus peritoneal pouch. So if the prolapse is more than 5 centimeters, there's a risk of fecal incontinence, and it contains peritoneal sac. And what is the surgeries? 3 surgeries you should remember for rectal prolapse. Thier's operation, Delorme's operation, and Attal-Mears operation. What is Thier's? Perineal procedure for rectal prolapse. Mucosal sleeve resection for prolapse is Delorme. Abdominal rectopexy is for Attal-Mears procedure. Now, high and low imperforate anus. So first of all, if the anus is imperforate, how do you diagnose in an infant? You put one coin closer to anal area, which is radio opaque, invert the baby and take X-ray. If the gas shadows do not rise, then you will identify that there is a imperforate anus. Is it high or low? Will be known by invertogram. This is called as, where the baby is inverted. At the anal place, there is a radio opaque thing kept, and the gas shadow will rise. Okay? Still there? Don't lose. So whenever imperforate anus, otherwise anal atresia is there, it is the congenital absence of the normal anal opening and the most common anorectal malformation in newborn. What is Bacterial syndrome? Vertebral anal atresia, cardiac abnormality, tracheoesophageal fistula, renal abnormality, and limb defects. In that part of it is anal atresia. It's called high type if the rectum ends above levatrinae, low type if it is through the levatrinae but fails to reach the perineum. High ki treatment ఏంటండి? Sigmoid colostomy initially. Sigmoid colon cut చేసి బయట పెడతారు. Finally you will do posterior sagittal anorectoplasty at 3rd to 6th month. Low అయితే, that means it pierced the levatrinae but did not reach the perineum. You will do primary anoplasty. You will manipulate the anus. No colostomy needed for low anal atresia. Okay. So this is the invertogram. Okay. So then what is pilonidal sinus, also called Jeep disease? So the hirsute male typically will develop a pilonidal sinus. Then coming to fissure ano, very common problem. So basically anal fissure and constipation are interlinked. Because the constipation, hard stools passing will cause a fissure, and the fissure will undergo anal sphincter spasm and worsen the constipation. Constipation was a fissure, fissure ki wajah se constipation. So the most common location is the posterior midline, anus anterior posterior. Posterior midline is the most common sign. So pain on defecation, bright red bleeding, presence of a mucosal tag like this is an indicator. How do you treat this? Use stool softener, topical nitrate to relax the sphincter. Worst case, lateral sphincterectomy. But that will lead to incontinence as a complication. Lastly, hemorrhoids. Hemorrhoids, where are they located? 3, 7, 11 position in this circular anal margin. Internal bleed, no prolapse, grade 1. 2, prolapse, reduce spontaneously. 3, reduce manually. 4, permanently prolapsed. And you call external, if it is below dentate line, they are very painful. Above the dentate line, not painful. Above and below dentate line, no different innervation. Somatic innervation is below the dentate line. Okay, doctor? So we'll continue tomorrow.
Right.
So I think we have accomplished quite a lot.
Yes.
Eh? So कितने घंटे पढ़े?
2 hours 15 minutes.
2 hours. So every day, every 2 days we finish big subjects, and every day one small subject like orthopedics, pediatrics, ENT, ophthalmology. 3 घंटे बस मस्त है. But I'll give you very concentrated notes which you try to do the revision, doctor. Thank you for patient participation. Join me every day early morning 5 o'clock. Thank you.